Hello everyone. In this session, we are going to discuss a very important topic, that is bone tumors. It's an ultra important topic from exam point of view. You frequently get long question as well as short questions from this topic. So here we will be discussing 6 bone tumors in detail, that is osteoid osteoma, osteochondroma, osteosarcoma, chondrosarcoma, Ewing sarcoma and giant cell tumor. And you frequently get questions on any of them as a long question or short question in your exam. So we will be discussing all these tumors in a fixed set of heading, and in the end we will compare them in a tabulated manner for better retention. I can challenge you that at the end of the session you can answer any question from this topic even without revision. So that will retain in your mind permanently. So let's start it. So here you can see we are starting the topic, the ultra important topic, that is bone tumors. So in this session, first of all, I will let you know the classification of bone tumors. We will be studying 2 types of classification. First classification is based on histogenic type, and second classification based on the location of the tumor in the bone. So we will be discussing 2 types of classification of bone tumors. After that, we will start individual tumors one by one. As I told you, we will be discussing 6 tumors: osteoid osteoma, osteochondroma, osteosarcoma, chondrosarcoma, giant cell tumor, and Ewing sarcoma. All these 6 tumors we will be discussing under a fixed set of heading, that is introduction for each of them, then most common age of presentation, the gender predilection, location, sites, radiological appearance, gross, microscopic appearance, clinical features, and spread if it is malignant. So we will be making a comparative table of all these 6 bone tumors in the end. One by one we will study and fill this table. We will see the details and fill it in short, so that in the end you can retain it better. You can just revise this table and everything will be there in this table. So let's start it. First of all, I will be telling you the classification. So we will discuss 2 types of classification of bone tumors. As I told you, the first classification is based on histogenic type. So we divide the bone tumors into 5 categories. Whether the bone tumor are bone forming, that is osteogenic in nature, or whether they are cartilaginous in nature, that is chondrogenic. So whether the bone tumors are osteogenic or chondrogenic, or whether they are hematopoietic in nature, or whether they are of unknown origin or neuroectodermal in origin. So we are dividing them in these 5 category based on their basic histogenic type. Now each category have two variants, whether it is benign or malignant. So we have benign tumors and malignant tumors in each category. So the bone forming tumors, that is osteogenic tumors, in the benign we are having osteoma, osteoid osteoma, and osteoblastoma. These are osteogenic in nature and they are benign. Among the malignant, it is osteosarcoma, the most common primary malignant tumor of the long bones. That is osteosarcoma, very important tumor. It's bone forming tumor and it's malignant. It is the most common tumor. You can say primary malignant tumor of the bones, of long bones. Now coming on the cartilaginous category, that is chondrogenic. In the chondrogenic, again we are having benign and malignant. In the benign, we are having osteochondroma, chondroma, and chondroblastoma. These are the benign tumors and they are cartilaginous in nature. They are chondrogenic in nature. Among the malignant, we are having chondrosarcoma. We are having chondrosarcoma and dedifferentiated chondrosarcoma. So basically we are having chondrosarcoma there. In the hematopoietic, there is no benign tumor, only malignant tumor is there, that is myeloma and malignant lymphomas. These are hematopoietic in nature. Among the unknown origin, in the benign tumor, we have giant cell tumor, simple bone cyst, aneurysmal bone cyst. Among the malignant category, we are having Ewing sarcoma, and neuroectodermal, it's chordoma. So among these, we will see details of the 6 ultra important tumors in each category. So among the osteogenic tumors, I will be telling you 2 tumors in detail, one benign, one malignant. Among the benign, we will see osteoid osteoma, and among the malignant we will see osteosarcoma. This is the most common benign bone tumor. This is the most common malignant bone tumor. We will be studying both of them in detail. Among the chondrogenic category, the cartilaginous category, again we will see 2 tumors in detail, one from the benign, one from the malignant. I will be telling you the detail of osteochondroma in detail from the benign category and chondrosarcoma in detail among the malignant category. Among the tumors of unknown origin, again we will see 2 tumors in detail, one benign, one malignant. We will see the detail of giant cell tumor, which is a benign tumor, but it is having malignant potential. And we will see the detail of Ewing sarcoma, which is very aggressive malignant tumor. So we will see the details of these 6, but you should know classification of all of them very clearly in which category they are coming. This is the first classification. Now coming on second classification. Before understanding the second classification, because second classification is based on the location of the tumor. You must understand the parts of a long bone. We divide the long bone into 3 parts. What are the 3 parts of a long bone? So we are having epiphysis, metaphysis, and diaphysis. So we are dividing the long bone into 3 portions. You can see this portion is known as epiphysis. The shaft of the bone, this is the shaft of the bone. The shaft of the bone is known as diaphysis. And the connection between epiphysis and diaphysis, epiphysis is end of the bone, the end of the bone, okay? And the shaft of the bone is diaphysis, and the connection between epiphysis and diaphysis is known as metaphysis. So this portion is known as metaphysis. So which tumor is arising from epiphysis, which tumor arising from metaphysis, and which tumor arising from diaphysis? Some tumor arise here, some here, some here, based on which this is the second classification of bone tumors. So you can see these all are epiphyseal tumors, these are metaphyseal tumors, and these are diaphyseal tumors. You can see it here. Among the epiphyseal tumors, we are having only 3 tumors here. Which 3 tumors we are having here? Chondroblastoma, giant cell tumor, and clear cell osteochondroma. Remaining all osteochondromas apart from clear cell, they are metaphyseal in origin. Only clear cell chondrosarcoma is epiphyseal in origin. Now the metaphyseal tumors are osteogenic sarcoma, simple bone cyst, aneurysmal bone cyst, fibrous cortical defect, chondrosarcoma except clear cell chondrosarcoma, osteochondroma, and chondroma, and osteoblastoma. So you have to learn this category, remaining all tumors arising from the diaphysis, you can learn like that. So you can see the same, whatever I told you here, you can see it here. You can see which tumors are arising from diaphysis, which are arising from metaphysis, and which are arising from epiphysis. You can see it here clearly in this diagram. One by one, when we will see the details of the tumor, we will see this diagram again, and we will see that particular tumor, it is arising from which portion of the bone. One by one we will see. Now before starting the details of the tumor one by one, I want to tell you this important thing. This is for your MCQ purpose. You frequently get MCQs from this portion. Do you know most common bone malignancy? So bone malignancies are of 2 types. The bone tumors or bone malignancies or bone tumors, you can say, are of 2 types, primary and secondary. What do you mean by primary and secondary? Primary bone tumors, they arise in bone itself. But the secondary bone tumors, these are the metastases. Basically, these are the tumors of some other organ in human body, and via blood or lymphatics, they are reaching the bone and involving the bone secondarily. So they are known as secondary bone tumors or metastases. So which is more common in bones, primary or secondary? So in the bones, secondaries are more common than primary. So most common tumor in the bone is secondary. That is metastasis. So first thing you have to learn, the most common tumor in the bone is secondary, not primary. Secondary is most common tumor in the bone. Among the primary, which is the most common? My next question. Among the primary, most common tumor in the bone is hematopoietic tumor. That is multiple myeloma. But mostly it involves the flat bones. It can involve long bones also, but mostly it involves the flat bones. Among the primary bone tumor of the long bones, most common tumor is osteosarcoma. So this is regarding the malignant bone tumors. Most common tumor in the bone is secondary. Among the primary, most common is multiple myeloma. But among the primary, most common malignant tumor of long bone is osteosarcoma. Now coming on benign bone tumors. What is the most common benign bone tumor? Not malignant. The benign bone tumor, it's osteochondroma, but actually it's not a true neoplasm, because here the growth stops with the cessation of growth at the epiphyseal plate. So that's why it's not a true neoplasm. Which is the most common true benign tumor of the bone? It's osteoid osteoma. So you have to mind your question very carefully, whether they are asking most common benign tumor or whether they are asking most common true benign tumor. If they are asking benign tumor, it's osteochondroma. If they are asking true benign tumor, it's osteoid osteoma. Most common tumor of the hand is enchondroma. So you have to learn all these things. So most common tumor, just most common tumor in the bone. Which one? Among it is secondary. So this one is simply secondary bone tumor. Secondaries are more common than primary. Now let's talk about primary. Most common primary malignant bone tumor. Malignant tumor in the bone. So answer is multiple myeloma, but it don't occur in long bones usually. So most common primary malignant tumor again, but that of long bones. So it is osteosarcoma that we will see today in detail. That is about the malignancies, the malignant bone tumors. Now let's talk about the benign bone tumors. Let me ask you the questions regarding the benign bone tumors. So most common benign bone tumor or most common true benign bone tumor. So these are 2 different questions. most common benign bone tumor and true benign bone tumor. So most common benign bone tumor is osteochondroma, but it's not a true tumor. It's not a true neoplasm. Among the true, most common benign is osteoid osteoma. So that you have to learn. And most common tumor of the hand is enchondroma. So you frequently get questions, especially MCQ questions or one-liner questions here. So let's start it one by one. We will see the details of all these tumors you can see. So we have to see the detail of the 6 bone tumors: osteoid osteoma, osteochondroma, osteosarcoma, chondrosarcoma, giant cell tumor, and Ewing sarcoma. So one by one we will take the details of them under a fixed set of heading. First I will let you know the introduction of each of them, then most common age of presentation, gender predilection, location, sites, radiology, gross, microscopy, clinical features, and spread. I request all of you to take out their your workbooks with you, or your if you are having the hard copy of Pathology Prof Buster, you can take out that hard copy. So this table, the blank table is given there. I want you to fill it there only. So after the description, this table it should be filled by your own handwriting so that you can retain it better. Otherwise, you can take out your simple notebook and start making this table with me. I will also fill it with you. So let's start with the first tumor, osteoid osteoma. I'm starting with the first one. In these headings only we will study. So let's start the introduction. As I told you, osteoid osteoma is the most common true benign tumor of the bone. It is the most common true benign tumor. It's not most common benign. If I remove the word true, then answer is osteochondroma, but it's not a true tumor. Osteochondroma is not a true tumor. Among the true benign tumor of the bone, it is osteoid osteoma. It is a very slow growing. Since it is benign, it's true benign tumor. It's slow growing. Most common age of presentation is 10 to 30 years. And most common it occurs in male more frequently as compared to female. So there is a gender predilection. Location, it occurs on the diaphysis of the bone. You can see it here. Can you see this one? It is occurring at the diaphysis, osteoid osteoma. It is occurring at the diaphysis of the bone. You can check in the classification also. And most common site is tibia. Most commonly it occurs in tibia. Radiological appearance, you can see it here. Can you see the tumor here? Appreciate the tumor here. The tumor is uppering, it is looking like a central focus or a nidus. It is surrounded by the sclerotic bone. So the tumor appears as a small nidus, and it is surrounded by the sclerotic bone. Dense sclerotic bone. So this is a radiological appearance. Can you say it with me? What is a radiological appearance? A small focus or a nidus. The small focus or nidus. It's a very small tumor. You can see it here. And it is always surrounded by dense sclerotic bone. So surrounded by dense sclerotic bone. This is the radiological appearance. You have to see it here, mark it here, understand it here. Rather than learning, please understand. Coming on the gross appearance of this tumor. Grossly, it is very well circumscribed. Can you make out the borders? So I can make out the boundaries or the borders of the tumor. It's well circumscribed. Since it's benign, it's not malignant. It is round to oval in shape. And it is having a hemorrhagic tan. Hemorrhagic gritty tan. If you feel it, it's gritty in nature because it is a bone forming tumor. It is osteogenic in nature. It's gritty in nature and it's hemorrhagic. Cut surface is hemorrhagic. So describe it. Don't read the description. Look at the image and describe it. So you can see it's well circumscribed. It's round to oval. Cut surface is hemorrhagic and it's gritty in nature. Coming on the microscopy. In the microscopy, the tumor cells are arranged in the form of a trabecule of woven bone. You can see this is bone. Appreciate the pink color lace-like thing. This is all woven bone. This is all tumor. The tumor is in the form of woven bone trabeculae. Woven bone trabeculae. They are lined by a single layer of osteoblast. You can appreciate this is the lining here. They are lined by a single layer of osteoblast. And the background is having the stroma. The background is having the stroma. The stroma is loose connective tissue that may contain dilated capillaries. Can you appreciate the dilated capillaries in the background? Appreciate the congested and dilated capillaries in the background in the loose stroma. So describe the microscopy. The tumor is in the form of bony trabeculae. Woven bone trabeculae. They are lined by a single layer of osteoblast and the background Background means stroma. It is loose and it contains the dilated capillary. So you should be able to draw it also. Okay. So the gross and microscopy is done. Coming on the clinical feature, the most important clinical feature is nocturnal pain. Patient typically have pain during night, severe pain during night. The midnight patient get up from sleep and say, I'm having severe pain at the site of the tumor, especially in the tibia if it is occurring in tibia. It is due to prostaglandin E2 production. It's a very important MCQ. Prostaglandin E2 production. The tumor cells do prostaglandin E2 production that causes nocturnal pain and it is relieved by aspirin. Since it is due to prostaglandin production, so it is relieved by the aspirin. Okay, so this is the clinical feature. So we are done with the first tumor. Out of 6, 1 is done, 5 more to go. Can we revise the first one and then move on the second one? So let's revise it. We are done with the most common true bone tumor. Benign bone tumor, osteoid osteoma. So in the introduction, the same line is given. It is the most common true benign tumor of the bone. It is the true benign tumor. Age 10 to 30 years. It is more common in males as compared to females. Location, it occurs at diaphysis of the bone. I have shown you the diagram also. Among the sites, most commonly it occurs in tibia. Now remember the 3 images, radiology, gross and microscopy. Please remember, in radiology, I have shown you a nidus which is surrounded by the sclerotic bone. I have shown this image to you right now. In the gross, I told you it's a very well circumscribed tumor. It is round to oval, cut surface is hemorrhagic and it's gritty in nature. In the microscopy, please remember the image. There are bony trabeculae, woven bony trabeculae which are lined by single layer of osteoblast. And background is having loose stroma containing dilated or congested capillaries. Clinical feature, nocturnal pain because of prostaglandin E2 production and that is relieved by aspirin. Since it is not a malignant tumor, there is nothing about the spread. So coming on the next tumor. The next tumor is osteochondroma. Let's come on the next tumor. The next tumor here we have to discuss is osteochondroma. Let's start osteochondroma. Can we start? Yes. So let's start osteochondroma. Osteochondroma, also known as osteocartilaginous exostosis. Learn the other name. Okay. It is the most common benign tumor, but it's not a true. It's not a true neoplasm because the growth ceases after the closure of the growth plate. That's why it's not a true neoplasm. It's the most common benign tumor, but most common true benign tumor is osteoid osteoma. You have to mind it. It occurs due to mutation of a gene. The name of the gene is EXT1 or EXT2 gene. It occurs due to mutation of these 2 genes and sometimes it's benign, but it can convert into malignancy, that is Chondrosarcoma. Rarely it converts into malignancy. Age, it occurs in adolescence. It occurs in adolescent age. So 11 to 20 years, you can say the adolescent age. And it is more common again in male as compared to female. Among the 6 bone tumor, only one of them, that is GCT, is common in female. Rest all of them are common in male as compared to female. Okay. Now coming on the location, this one occurs at the metaphysis of the bone. You can see it here. Can you appreciate osteochondroma? Appreciate, it's like a cap-like tumor. You can appreciating here a cap-like tumor. So it is occurring at the metaphysis, not at the diaphysis, in contrast to osteoid osteoma, the first tumor we have seen that was arising at the diaphysis. But you can see this osteochondroma is arising at the metaphysis. So it is arising at the metaphysis of the long bone. Most common location is knee joint. What is knee joint? Lower end of femur or upper end of tibia. So please learn lower end of femur or upper end of tibia. So either lower femur or upper tibia. So near the knee joint it occurs. Lower femur, upper tibia. It's like that. Radiological appearance is very typical. It appears mushroom shape, or you can see like a cap. The tumor is having a cap which is made up of cartilage. So you can see it's mushroom shape or it's like a cap. It's like a cap. The cap is made up of hyaline cartilage and it's varying in thickness. So that is the typical radiological appearance. It's like a protuberance. The tumor is appearing. That is gross. That is radiology. Now gross is also same. You can see the cap. Appreciate the same cap here also, like a protuberance is there. So you can see it's mushroom shape. Cap is there, which is coming exophatically out. It is protruding out and it is made up of the cartilage. And the center contains the bone. The center contains, so cap is made up of cartilage and this portion, central portion, contains the lamellar bone and this portion contains the cartilage. So typical gross is there. It's like this. Now coming on the microscopy, in the microscopy again we can make out 2 portion. Can you see the 2 portion? Outer portion, inner portion. Outer portion is cartilage. Can you make out this portion? This portion is completely cartilage. So you have to draw a cartilaginous lesion here. Appreciate this portion. It is cartilaginous in nature. So outer portion is cap and made up of mature cartilage. It's not malignant cells. The benign cartilage is there. And inner portion contain lamellar bone and bone marrow. Appreciate the inner portion, this portion. It contains simple bony trabeculi and bone marrow. Sometimes it can be there. So outer portion, inner portion. This is the microscopy. Coming on the clinical features, it is usually asymptomatic, but sometimes it can produce deformity. But usually it is asymptomatic, but if it is very big, so outer deformity can be seen in the form of a cap or protuberance like that. So this is the clinical feature. We are done with this also. So let's revise it very quickly. Can we revise it together? So we have completed 2 benign tumors till now. 1 bony in origin, 1 cartilaginous in origin. That is, one is osteogenic, one is osteogenic in nature, and one is cartilaginous in nature. So you can see here osteoid osteoma versus osteochondroma. So currently we have completed osteochondroma. So osteoid osteoma was the most common benign tumor of the bone. It's a true benign tumor. Osteochondroma is also most common benign tumor of the bone, but it's not true. So mind the word here. True and not true. Both of them are most common benign tumor of the bone. This one is true, this one is not true tumor. Here the age was 10 to 30 years, but here the most common age of presentation is adolescence. Both of them are more common in male as compared to female. Osteoid osteoma was arising from diaphysis of the bone. In contrast to that, osteochondroma arises from metaphysis of the bone. Most common site for osteoid osteoma was tibia. Here the most common site is knee joint. I mean, it's upper tibia and lower femur, either lower femur or upper tibia. Radiological appearance for osteoid osteoma, it was the central nidus which is surrounded by sclerotic bone. But here in osteochondroma, there is a cap. I have shown you the diagram. Imagine the diagram. There is a cap which is made up of hyaline cartilage. Microscopy, here there was woven bone which is lined by osteoblast. Here I told you 2 areas, outer and inner. The outer area is cartilaginous cap, and inner area, it is having lamellar bone along with the bone marrow. And here we are having nocturnal pain, but here usually it is asymptomatic, but rarely it can produce the deformity. So that is the osteochondroma, and we have compared the 2 benign tumors. One is true, one is not true. The most common 2 benign tumors of the bone are done. Coming on the third one, let's start the third one, osteosarcoma. It is the most common tumor, the malignant tumor, and very important from exam point of view. So let's start osteosarcoma. So as I told you, among the primary bone tumors, most common malignant primary bone tumor of the long bone is this one. It is second to multiple myeloma. Most common primary malignant tumor is multiple myeloma. Second most common is this one, but among the long bone, this is the most common. Why it is known as osteosarcoma? Here the tumor cells form the bone. The tumor cells are forming the bone. That's why it's osteoid in nature. Here the sarcoma cells are synthesizing the bone. I will show you the diagram. Presence of osteoid is mandatory for diagnosis. So that is the introduction. Coming on the pathogenesis. What is the pathogenesis? There are 2 types of osteosarcoma, primary and secondary. In primary, the underlying bone is unremarkable. It occurs due to mutation of certain genes. Which gene? Either mutation occurs in retinoblastoma gene, or there is Law-Frawny syndrome, that is mutation of P53 gene, or there is mutation in INK4A, which are coding P16 and P14 proteins, or there can be mutation in MDM2 or CDK4. So you can see the mutation, but most common mutation, it is due to retinoblastoma gene. So this is primary osteosarcoma. In secondary osteosarcoma, the pre-existing bone disorders are there. Here the bone was healthy. It is due to the mutation in the gene in primary one. But in secondary, there is pre-existing disorder in the bone. Maybe there is Paget disease in the bone, or maybe some radiation exposure to the bone is there, or pre-existing benign bony lesions is there, like fibrous dysplasia, osteomyelitis, bone marrow infarcts, like that. So that is either in primary, the bone is unremarkable, but it is due to mutation in the genes. In secondary, there is pre-existing bony lesions are there. Now coming on the classification, we divide the osteosarcoma into 2 categories. What are the 2 types of osteosarcoma? One is central, one is surface. The central ones start from the medullary cavity. It arises from the medullary cavity. That's why also known as medullary or conventional osteosarcoma, also known as classical osteosarcoma. So central, medullary, conventional, classical osteosarcoma is same. And the other one, they are arising not from medullary cavity. They are arising either from cortex or outer to cortex. So these are known as surface osteosarcoma. The medullary or central one, there are various histological types of that, but most common is osteoblastic. We will see that in detail. And among the surface, there are two types, parosteal and periosteal. We will see the detail of both of them one by one, parosteal as well as periosteal. Parosteal also known as juxtacortical. We will see both of them one by one. So currently, first we will see the detail of central. We will see this detail of the central, and then we will see the details of the surface one. So let's start the central osteosarcoma. Central, also known as medullary, also known as conventional, also known as classical osteosarcoma. It is the most common and classical type. Age, it is bimodal in distribution. What do you mean by bimodal? If it is primary, it occurs in young age, 10 to 20 years. But if it is secondary, it occurs after 40 years. Primary means due to mutation and secondary means pre-existing bony disorder. So if it is primary, it occurs in young age or childhood, 10 to 20 years, adolescence you can say. But if it is secondary, it occurs in old age after 40 years. Again, it is more common in males as compared to females. There is gender predilection. Location, it occurs at metaphysis. It occurs at metaphysis. It arises from metaphysis. You can see it is arising from the medullary cavity of the metaphysis. Medullary cavity of the metaphysis. Among the sites, again, the most common site is say the knee joint. What do you mean by knee joint? Lower femur, upper tibia. Either lower femur or upper tibia. You can see lower end of femur, upper end of tibia around the knee joint. Or sometimes it can occur upper end of humerus also. Or it can occur in the pelvis also. It can occur in the jaw bones, vertebrae and skull also. But less commonly, most commonly around the knee joint. Now radiological appearance is very typical. You have to learn two findings in radiological appearance. What are the two findings? The first finding is sunburst appearance. See the tumor. See the tumor radiologically. Can you see the tumor cells? The tumor is extending into the soft tissue. When the tumor is extending, can you see the tumor is extending in the soft tissue like this? When the tumor is extending in the soft tissue, parallel lines of mineral deposition gives a appearance of the rays of the sun. So you can see this is the tumor. It is looking like sun. It is looking like sun. And when the tumor is spreading in the soft tissue, so parallel lines are there. The parallel lines of mineralization in the tissue. You can appreciate the parallel lines of mineralization in the tissue. So first compare the tumor with the sun. We are comparing the tumor with the sun, and the spread of the tumor in the soft tissue is like parallel lines of mineralization. It is looking like the sun. It is known as sunburst appearance. So please learn this catchy word. You have to highlight this word in your answer copy. Sunburst appearance. The first important radiological finding. The second important radiological finding is that when tumor is starting from here, the medullary cavity. Okay. After that, tumor infiltrate the cortex. It is growing. It is infiltrating the cortex. After medullary cavity, it is coming in the cortex also. It's lift the periosteum. Can you see? It is lifting. Can you see this is periosteum? Appreciate the periosteum, and the periosteum is lifted here. Let me highlight. So you can see this is periosteum here, and it is lifted by the tumor. It is lifted. So you can see the tumor starting from the medullary cavity. It is growing the cortex. After that, it is lifting the periosteum. Since the periosteum is lifted, there is a space. There is a space between the periosteum and the cortex. This is cortex. Can you appreciate the space? It is making a triangle. So this triangle is known as Codman triangle. So there is a space between the cortex and the lifted periosteum. And radiologically, it appears as a triangle. Appreciate this triangle. You can see the yellow color is the periosteum, the red color is the cortex. So after cortex, the periosteum is lifted by the tumor. And you can appreciate this as a triangle. We can make a triangle between the two things. So you can see this is the periosteum, and you can see this is cortex. So the space between the periosteum and cortex is making a triangular appearance, and that is known as Codman triangle. Very important question. It is characteristic for this tumor, but not diagnostic. It is characteristic feature. You can appreciate it here. You can see a triangular thing here. You can appreciate. So the periosteum is lifted up. So learn the two important radiological features of osteosarcoma. One is sunburst appearance and second is Codman triangle. Sunburst appearance is due to the spread of the tumor in the soft tissue, giving parallel lines of mineralization in the soft tissue. It is known as sunburst appearance. And Codman triangle, when the tumor starts from the medullary cavity, it grows, lift the periosteum. So there is a space between the cortex and the periosteum in the form of a triangle. It is seen. It is known as Codman triangle. So the same thing is written. Tumor arises centrally at the metaphysis in the medullary cavity. Here, the tumor is starting. After that, it is growing laterally on either side and going in the cortex, breaking the cortex. And after that, it's lift the periosteum. It is lifting the periosteum. It is lifting the periosteum, making the Codman triangle. And after that, it enters the soft tissue and giving the sun ray appearance. So first Codman triangle is made and then sunburst appearance. So these are the two important radiological findings. Now coming on the gross. In the gross, you can see the tumor is appearing as gray, white, bulky mass. The tumor appears as gray, white, bulky mass. If you cut it, you can see the cut surface is hemorrhagic and necrotic. Hemorrhagic and necrotic. The cut surface is hemorrhagic and necrotic. See the microscopy of the tumor. In the microscopy, in the image, I can see two things. Number one, tumor cell, and number two, the bone formed by the tumor cells. First, describe tumor cells. The tumor cells are sarcoma cell. Can you describe them? Can you see the tumor cells in the image? These all cells are tumor cells. All of them are tumor cells. Describe them. How you can see in the image. Don't read the description. Don't learn it. See the image and describe them. So tumor cells are undifferentiated in nature. They are varying in shape and size. Some are small, you can see. Some are small, some are large, some are small, some are large. So it is pleomorphism. They are showing pleomorphism, that is variation in shape and size. They are showing hyperchromatism. See their nucleus. Their nucleus is dark, darkly condensed chromatin is there. You can see condensed chromatin, dark color nucleus is there. That is hyperchromatism. And they are showing mitosis very frequently. You can appreciate, you can see some of them are showing the mitosis. You can see the spindle fibers, atypical mitosis are frequent. So please learn the tumor cells are undifferentiated, number one. They are hyperchromatic and they are showing pleomorphism. Hyperchromatic means dark nucleus. Pleomorphism is variation in shape and size. And they show the mitosis. Learn these properties of the sarcoma cell. The most important feature, the sarcoma cells synthesize the bone. Can you appreciate the bone here? These sarcoma cells are making bone. They are forming bone. They are synthesizing bone. And the bone is arranged around these sarcoma cell. Can you see the pink color bone? The bone is in the form of a lace-like pattern. It is known as lace-like pattern. Lace-like pattern. It is osteoid matrix, the bone formation. It is forming the matrix. So the tumor cells are synthesizing the bone, which is forming the matrix, which is forming the background. So you have to draw the diagram like this. First, you have to draw the tumor cells. You have to draw the tumor cells like this. Like you have to draw, some cells are small, some are large. You have to show the pleomorphism. In some of them, you have to show the mitosis also. Atypical mitosis is there. So you have to draw many tumor cells in clusters, singly, and they are forming the bone. So you have to form the bone, the osteoid, which is around the tumor cells in the form of lace-like pattern. It is known as osteoid matrix. So two things are there. So you have to label it properly and you have to draw these two things. So that is the microscopy. You can see it. Very good diagram. So draw the tumor cell first and draw the bone formed by the tumor cell. So two things you have to show in the diagram. The tumor cells are there. Some of the tumor cells are in the form of giant cells. Tumor giant cells. You have to show mitosis. These are malignant tumor cells. And you can appreciate the lace-like pattern in the bone. The bone which is formed by the tumor cell is arranged in the form of a lace-like pattern. So that is the thing. The same thing is shown here. The lace-like pattern of the bone you can appreciate here also along with the tumor cells. Clinical feature, painful mass. Painful progressive mass. It's very painful. Painful progressively enlarging mass around the knee most commonly. So involved area is swollen and tender. So it's swollen. If you touch it, it's highly painful. It's tender. The joint is affected. The joint function is reduced and serum alkaline phosphatase is increased. So these are the clinical features. You can appreciate the painful enlargement of the mass. It's very painful. It's swollen. It's tender. The joint function is reduced. Coming on the spread, since it is a malignant tumor, we have to talk about the spread. There are two types of spread, local and blood. Blood is hematogenous, the local spread and blood spread. Local spread, first, it starts from the medullary cavity and goes to the cortex and destroy the cortex. Destroy the cortex. It destroys the nearby cortex. After that, it perfore the periosteum and lift the periosteum and make the Codman triangle. So periosteum is destroyed. After that, it spread along the medullary cavity. So it spread horizontal also, it spread vertically also in the entire medullary cavity. After that, it goes to the epiphysis also. From metaphysis, it goes to the epiphysis and involve that also. After that, it involves the soft tissue also. So it is growing horizontally also, vertically also. So it starts from the medullary cavity. Say it again. It starts from the medullary cavity first. Then it destroys the cortex, then it destroys the periosteum, then it spread in the soft tissue. It involves entire medullary cavity, and from metaphysis, it goes to epiphysis also. So this is all about the local spread. Don't learn it, you can understand it well. And the blood spread via blood, it goes to any organ in the blood. Most commonly, it goes to the lung. most commonly, but it can goes to other bones, pleura, brain, and heart also. It's a malignant, dangerous tumor. Prognosis is usually poor. So we are done with the central osteosarcoma, that is medullary, conventional, or classical osteosarcoma. And now we are coming on surface osteosarcoma. As I told you, surface osteosarcoma are of two types. We will discuss both in detail, parosteal and periosteal. Parosteal also known as juxtacortical. So let's start surface osteosarcoma. Why they are known as surface osteosarcoma? How they are different from the conventional one, the central one? The central one arise from medullary cavity. They arise from medullary cavity. They arise from the center of the bone, but they arise from the surface of the bone. So that is the difference. That's why they are known as surface osteosarcoma. So they are only 5% of total osteosarcoma. 95% are these only. They are very rare. Only 5% of the total osteosarcoma are surface osteosarcoma. They are slow growing, and as compared to medullary osteosarcoma, and they arise from the surface. Now what are the two types, parosteal and periosteal? See the diagram. Can you see the diagram? One is par. See the spelling. Par. Osteal, also known as juxtacortical. And second is periosteal. So there is a difference in par or peri. One is parosteal, one is periosteal. Parosteal, periosteal. The parosteal also known as juxtacortical. Now see the difference between them, you will understand. So the parosteal arises outer to the cortex. It grows longitudinally also, laterally also, but outer to the cortex. Periosteal between the cortex and the periosteum. It is between the cortex and the periosteum. Parosteal outer to the periosteum also. Okay, so that is the difference. You can see it very clearly in the diagram. So let's start with parosteal or juxtacortical. So it is uncommon, very slow growing form of the osteosarcoma. It's very uncommon, it's very rare, it's very slow growing. It arises on the surface of the bone. It is outer to the periosteum also. Outer to everything. Outer to cortex, outer to periosteum, the tumor is. It's grow only on external surface of the bone. It grow linearly, longitudinally, only on external surface of the bone. It do not involve medullary cavity. No involvement of the medullary cavity, that is parosteal. It occurs in 3rd to 4th decade of life. There is no gender predilection in contrast to central osteosarcoma, which was more common in male as compared to female. Okay. And it is occurring in older age, 30 to 40 years, in contrast again to central osteosarcoma, which were occurring as a bimodal distribution. But here it is older age, 30 to 40 years or 3rd or 4th decade. Location, it occurs at metaphysis of the bone. Site, most frequently femur or humerus. And it is slow growing and is having excellent prognosis, in contrast to again central one, which is having very worse prognosis and it's very fast growing. This one is slow growing, having excellent prognosis. Site is more or less same. You can see it can occur on femur as well as humerus. Location is also same as that of central. Both of them are at metaphysis, but gender prediction is different. Here it is same in male and female, but in contrast to central one, which was more common in male. So you have to see the differences from the central one. Coming on the second one, the second is periosteal. The periosteal is between cortex and periosteum. You can see here the tumor. So this is cortex, this is periosteum. The tumor is between them. But in contrast to parosteal, it is outer to cortex as well as periosteum. Outer to that. But this one is between cortex and periosteum. So it arises between cortex and periosteum. It's a high-grade osteosarcoma. It is not slow growing, it's high-grade. And predominantly it contains cartilage. It occurs in young age, nearly 25 years. It is also same in male and female. There is no gender predilection, but it occurs in diaphysis. The parosteal was occurring in metaphysis. This one occurs in diaphysis. The site is same, tibia or femur, and it is also slow growing as compared to central one. So you have to compare the central osteosarcoma with surface osteosarcoma. The surface are of two types, parosteal or periosteal. You have to do the comparison between the both. So central one occurs 10 to 20 years. It is bimodal, but the primary one occurs 10 to 20 years of age. This one usually occurs in older patient. I told you 3rd decade, 4th decade or 25. Parosteal occurs in 3rd or 4th decade. Periosteal occurs at age of 25. Central one is more common in male as compared to female, but par as well as periosteal, both of them are same in male and female. Central one occurs at metaphysis. Parosteal arises from metaphysis, but periosteal arises from diaphysis. The location is more or less same, femur, tibia, here also femur, humerus. Okay. Pathogenesis, I told you. Behavior, this one is highly malignant, but these are slow growing. Grossly, this one is bulky, necrotic, areas of hemorrhage. It is having Codman triangle. Here they are smaller, well-formed tumors are there. Okay, and spread here, blood spread is there, that's why having poor prognosis. Here recurrences are common but relatively having better prognosis as compared to central one. So you have to learn these differences. It's very important question. So we are done with this tumor. Also the third one, very important tumor, that is osteosarcoma. So I told you this one is the most common primary malignant tumor of the long bone. So see, if I ask you most common benign tumor of the bone, true benign tumor of the bone, it's osteoid osteoma. If I ask you most common benign tumor but not true, benign tumor of the bone but not true, so it's osteochondroma. If I ask you most common malignant tumor among the primary bone tumors, so answer is osteosarcoma. So see the three things, and that's why comparison is important. This comparative table is going to be a very important table for last time revision. Now see here the age group. Now here I have written all the detail of central osteosarcoma. I have not written the detail of surface osteosarcoma, that is parosteal or periosteal, because they are very rare. 95% osteosarcoma are central only, that is medullary, classical, conventional. So all the detail here written in this table is of central only, central osteosarcoma. So here it is bimodal in age. So the primary occurs 10 to 20 years of age and the secondary occurs after 40 years of age. Again, it is more common in male as compared to female. It arises from the metaphysis of the bone. The location is same near the knee joint, either upper tibia or lower femur. Radiologically, two important appearance, sunburst appearance and Codman triangle. You should know the description. Why sunburst appearance? Why Codman triangle? And you should be able to draw it in your exam beautifully. You should be able to show the sunburst appearance of the tumor. You should be able to show the Codman triangle and you should describe them, why they appear. After that, grossly, it's a bulky mass with areas of hemorrhage and necrosis. Microscopically, two things in the microscopy. One tumor cell known as sarcoma cell. They are pleomorphic, they are hyperchromatic, having a hyperchromatic nucleus, they are having giant cell, they are having mitosis, they are undifferentiated, like that. And they form the bone. The bone look like lace-like pattern. It forming the osteoid matrix. It is known as osteogenesis. So you should be able to show these two things in the diagram very beautifully and label them. So this is the microscopy. Among the clinical feature, it's a painful mass. It's a very rapidly growing painful mass. It's tender, it's swollen, like that. Spread is there, local spread as well as blood. Via blood, most commonly it goes to lung. So you should be able to describe it completely with the help of diagrams. Now coming on the next tumor, the cartilaginous malignant tumor, that is chondrosarcoma. So let's start the next tumor, that is chondrosarcoma. It is malignant tumor of the chondroblast. It is a malignant tumor of the chondroblast. It is characterized by production of neoplastic cartilage. It is also cartilaginous tumor, but neoplastic. I told you one more cartilaginous tumor, that is osteochondroma, in which cartilaginous cap was there, but that was benign cartilaginous tumor. This one is malignant cartilaginous tumor. Neoplastic cartilage is there. Age group, it occurs relatively old age, 40 to 60 years. Again, it is more common in males as compared to females. Location, it occurs start from the central medullary cavity from the diaphysis. Can you see in the diaphysis, this is chondrosarcoma. It is arising from the central medullary cavity from the diaphysis. So location is, you can say, medullary cavity in the diaphysis. Sides, it mostly occur at the pelvic bone. Can you see? Mostly it occurs in the pelvic bone. It occurs in the shoulders. It occurs in the ribs. And rarely it occurs in the long bone. So these are the sites you can see. Radiological appearance is very important. The tumor arises from the medullary cavity. You see, the tumor is arising from the medullary cavity. Then it perforates the cortex. Slowly it grows in the cortex and perforate the cortex. After perforating the cortex, it goes in the soft tissue in the form of calcification and ossification. Calcified matrix is there. You can see the calcified matrix is there. The calcified matrix is appearing in the form of popcorn calcification. It is looking like popcorn. Do you see popcorn? Have you seen popcorn? Do you eat popcorn? It is looking like a popcorn calcification or fluorescent densities with ring-like ossification. Can you see fluorescent densities? Can you appreciate all these fluorescent densities? Let me highlight with ring-like ossification. So say popcorn calcification or fluorescent densities with ring-like ossification. That is the typical description, the radiological appearance you have to describe. Coming on the gross, it's a large bulky tumor, but cut surface, since it's a cartilage, the cut surface is bluish in nature. It is having a bluish tinge. It is having a light bluish translucent tinge. Have you seen a cartilage? How does the natural cartilage look like? It is having a bluish tinge. Appreciate this bluish translucent appearance. It's myxoid or mucoid field. It is having spotty calcification. Small calcifications you can appreciate in between. The ring-like ossifications is there. So that is the gross appearance. Coming on the microscopy. In the microscopy, there is malignant cartilage cells. Can you appreciate all this? This is cartilage. Appreciate the background. The background is mucoid or myxoid. The background, the stroma is mucoid. In the cartilage, we are having mucoid or myxoid stroma. I guess you know that. So the cartilage, you can appreciate this is a cartilage because the background is bluish in nature. It's mucoid, it's myxoid in nature, and it contains cell in that. Which cell in that? The cells are malignant cartilage cells. The malignant cartilage cells. Now looking at this cell, looking at the mitosis and atypia and cellularity of this cell, we can decide there are 3 grades in this. Grade 1, grade 2, grade 3. So chondrosarcoma are of 3 grades. Grade 1, grade 2, grade 3. You don't have to write this in your exam. Just for understanding, you should understand there are 3 grades. So so you can see the matrix is same. The background matrix is bluish, mucoid or myxoid. Don't concentrate on the matrix. Concentrate on the cells, the malignant cartilaginous cells. Can you appreciate the cells are in clusters here? You can see all these cells. All these cells are in clusters. Look at the mitotic activities of the cell. If the mitosis is low, it is grade 1. If mitosis is frequent, it's high grade. Look at the cellularity. If cellularity is low, it's grade 1. If cellularity is high, it's high grade. So you have to look for cellularity, you have to look the mitosis, and if it is an intermediate, it is grade 2. So mild cellularity, moderate cellularity, high cellularity, grade 1, 2, 3. Mild mitosis, mitosis is rare, mitosis is intermediate, or mitosis is very frequent, depending on which we decide the grade. So for grade, you have to look for 2 criteria, cellularity and mitosis. So it is of 3 grades. So we see the cellularity of these cells and mitosis of these cells. What are these cells? Malignant cartilaginous cells, and background is same. Appreciate the background. It is bluish, mucoid or myxoid background. Clinical feature, again, it's painful, progressive, enlarging mass. The same like osteosarcoma, chondrosarcoma is same, and spread is also same. The local spread and blood spread. Blood spread most commonly occurs to the lung, and local spread, locally it's very aggressive in nature, and it spread to the soft tissue very frequently. So we are done with the 4th also. Now we are left with 2. So we are done with the 4th also, that is chondrosarcoma. Let's revise it quickly. So it is a malignant tumor of the cartilage. Most common age of presentation is 40 to 60 years. Again, it is more common in male as compared to female. And it arises from, you can write down diaphysis. It arises from diaphysis. Okay, the medullary cavity of the diaphysis. Location, it arises most commonly from pelvis, followed by shoulder, followed by ribs, followed by long bones. Radiological appearance, here we have popcorn calcification. Remember the diagram with ring-like ossification. Grossly, it is having a bulky mass with cut surface mucoid or myxoid bluish tinge. The cut surface is having. Microscopically, we are having 2 things. The background is mucoid or myxoid, but it is having the cells, the malignant cartilaginous cells, based on which, based on the mitosis and cellularity of these cells, we divide them in 3 grades, grade 1, grade 2, grade 3. Again, it's a painful mass, and spread is same, local and blood spread. So that is the thing. Now compare all of them. Okay, in the end, we will do the comparison. Don't worry. Coming on the 5th one, the giant cell tumor. Let's start it. So giant cell tumor, also known as osteoclastoma, because it is having osteoclastic cells. What are osteoclastic cells? The osteoclast type cells are the giant cells. They all have multiple nucleus. Osteoclast type giant cells are there. That's why it is known as osteoclastoma. It is a primitive stromal, it is a tumor which is arising from the primitive stromal cells. It's locally aggressive, although benign, but it can convert to malignant. It is a locally aggressive, but although it's benign, but sometimes it can be atypical and convert into malignancy. Most common age of presentation is 20 to 40 years. It is the only bone tumor which is more common in female as compared to males. Till now, all the bone tumors I told you, they are more common in male as compared to female, but this one is more common in female as compared to male. Location, it arises from epiphysis. Can you see giant cell tumor? I'm telling you, it is arising from epiphysis, not from diaphysis, not from metaphysis. Till now, all the tumors I told you, whatever I taught you, I told you either they are arising from diaphysis or from metaphysis. But this one I'm telling you arises from epiphysis. And this one more common in females as compared to males. So some unique features are there. You have to learn that. Most common site, again, the knee area. Lower femur, proximal tibia. Lower femur, upper tibia. So that is the most common location. Radiology, very typical radiology. So it's a lytic lesion. Can you see? It's a lytic lesion. It arises as a lytic lesion. It arises as a lytic lesion, grows slowly, expand in the bone and destroy the overlying cortex. So tumor produces a bulging soft tissue mass surrounded by a thin rim of calcification. On radiology, it is known as soap bubble appearance. Can you see? Small bubble-like appearance. You can see. It is known as soap bubble appearance. Please learn this appearance. You have to learn these catchy words and you should be able to recognize them in the image if it is coming as an image-based question in your exam. So these are the spotter image. So it's a giant cell tumor, typical soap bubble appearance you can see. Grossly, you can see the same soap bubble appearance in radiology. Grossly, it is appearing as honeycomb appearance. So you can see large tumor is there. It is having multiple small cysts which is filled with blood. So hemorrhagic cysts are there. Numerous hemorrhagic areas are there, which is giving a sponge-like appearance. It is known as honeycomb appearance. So in the radiology, learn one word, soap bubble appearance, and in the gross, learn one word, honeycomb appearance. The same soap bubble appearance here is appearing as a honeycomb appearance because multiple small cystic areas are there which are filled with blood. It is giving a sponge-like appearance. It is known as honeycomb appearance. Now coming on the microscopy, again we see two types of cells. See the image. Don't read the description, see the image. In the image, you can see two types of cells. What are the two types of cells? You can see these all are mononuclear cells. Can you see? Neoplastic cells are mononuclear cells. These are tumor cells, mononuclear cells. All of them are neoplastic stromal mononuclear cell, one nucleus. And we are having few giant cells. Appreciate these are the giant cell. Appreciate it is multinucleated. These are the giant cells. These are not neoplastic. So multinucleated giant cells. One is neoplastic mononuclear stromal cells and the other is multinucleated giant cell. Among the two, the neoplastic cell, the tumor cells are mononuclear one. Okay, we call it GCT. So usually students think that giant cell tumor, the giant cells are the culprit. The giant cells are the tumor cells. No. Giant cells are not tumor cells here. The mononuclear stromal cells are the culprit. They are the tumor cells. So can you describe the mononuclear cells first? Can you see they all are very uniform. They are oval. They are plumb. They all are same looking. Okay. They all have a prominent nucleoli. They have scanty cytoplasm and they have mitotic activity also. You can see some of them showing mitosis. So that is the mononuclear cell. They are uniform, no pleomorphism. They are plumb. They have scanty cytoplasm and they have mitotic activity. So that is stromal cells. Now describe the giant cells. In the background, you can see numerous giant cells containing many nucleus in them. They can have 100 or more nucleus in them. So that is a description of giant cell. You should be able to draw the diagram and label the two types of cells very clearly. You can see only two labeling in the diagram, mononuclear cell and giant cell. The giant cells, the multinucleated giant cell, mononuclear cell, multinucleated giant cell. The mononuclear cells are stromal cells. The multinucleated cells are giant cells. You should be able to give their description, their size, their nucleus and all the things. So this is the diagram, the same diagram. Appreciate the mononuclear cells and appreciate the giant cells. Describe the mononuclear cells. Mononuclear cells are uniform, plumb, scanty cytoplasm, prominent nucleoli, and they are malignant cells. They are having mitotic activity. Describe the giant cells. The giant cells are very big. They are having more than 100 nucleus. Some of them may be having, and that's it. That's it. And they are not malignant in nature. Coming on the clinical feature, pain is there, arthritis-like symptoms is there, and sometimes the fracture of the bone occur. In the bone, the fractures can occur because of this tumor. Spread. Local spread, blood spread. Blood spread occurs rarely, but if it occurs, it goes to the lung. And local spread, it can go to the cortex and it can involve the periosteum. It can involve the joint capsule and synovial membrane also. That is the local spread. So we are done with giant cell tumor also. So giant cell tumor also known as osteoclastoma. It is a tumor which arises from the primitive stromal cells. In the diagram, I have shown you two types of cells. Now, the mononuclear stromal cells. So these are the primitive stromal cells which convert into malignancy. Primitive stromal cells, the mononuclear cells, that's why they are tumor cells. It is the only bone tumor which is more common in female till now. See, remaining all I told you more common in male, but this one is more common in female. This is a tumor which is arising from epiphysis. Rest all were arising either from diaphysis or metaphysis. This one arising from epiphysis. The location is the knee joint, that is lower femur, upper tibia. And Radiologically, it is having soap bubble appearance because of multiple cystic spaces in that. Grossly also it is known as honeycomb appearance, the same sponge-like, multiple cystic spaces which are filled with blood. Microscopically, you have to describe two types of cell, mononuclear cell, multinuclear cell. Mononuclear cells are stromal cells, neoplastic cell, tumor cell, and multinuclear cells are giant cells. Clinical feature, the person have the pain and pathological fractures are common, and spread is same, local and blood spread. Now coming on the last tumor, the Ewing sarcoma. So let's start Ewing sarcoma. The last tumor is Ewing sarcoma. Ewing sarcoma, also known as primitive neuroectodermal tumor. It is also known as primitive neuroectodermal tumor. We call it PNET. Primitive neuroectodermal tumor, we call it. These are the malignant small round cell tumor. It's a primitive malignant small round cell tumor of the bone and the soft tissue. And it is very aggressive tumor. It occurs in children 10 to 15 years of age. In children, it is the second most group of bone sarcoma after osteosarcoma. So after osteosarcoma, the second most common tumor, the bone tumor in the bone, is Ewing sarcoma. Again, it is more common in male as compared to female. There is a pathogenesis. It occurs, Ewing sarcoma occurs due to some mutation, due to some translocation. Which translocation? First, learn 3 genes on 3 chromosomes. There are 3 genes on 3 chromosomes. There is a gene known as EWS gene, which is located on chromosome number 22. Chromosome number 22. This is the most common gene which is involved in Ewing sarcoma. The second gene is known as FLY1 gene. FLY1 gene. It is located on chromosome number 11. And third gene is known as ERG gene. It is located on chromosome number 21. So please learn the location of the 3 gene on 3 chromosomes, chromosome 22, 11 and 21. Now 2 type of translocations are common in Ewing sarcoma. Most common is this one and less common is this one. Most common is 11-22 translocation. 11-22, in which translocation occurs between these 2 genes. So FLY gene go to EWS. EWS from 22 come to chromosome number 11 and form a fusion gene. So it is known as FLY1 EWS fusion gene is formed. And second between 21 and 22. So second between 21 and 22. So 22 is involved in both of them. So either it is 11-22 or it's 21-22. If you can learn the name of gene, it's good. If you can't learn the number of chromosomes. So learn 2 translocation, please. So learn 22 is common in both of them. That is EWS gene is common in both of them. Okay, so either 11-22 translocation or 21-22 translocation. So 2 type of translocations can lead to Ewing sarcoma. That is the summary. This one is more common. This one is less common. So please learn the 2 type of translocation. 22 is common in both of them. Either the translocation occur between 11 and 22 or it is 21 or 22. So please learn it. You get MCQs also on this and it's a very important thing. So you can learn the translocation and the same thing you can see on chromosome number 22 we are having EWS gene and on chromosome number 11 we are having FLY1 gene. So during translocation that EWS gene goes to the FLY1 and form a fusion gene. Because of formation of the fusion gene, c-MYC get activated and it causes uncontrolled mitosis of the cell and that's why it leads to Ewing sarcoma. So this is the pathogenesis. Coming on the location, it arises from the diaphysis. Can you see Ewing sarcoma? It is arising from the diaphysis. So it is arising from the diaphysis. Please learn Ewing sarcoma. Most common site is humerus, tibia, femur among the long bones and among the flat bones it can arise from the pelvis also. Radiology is very typical. You can see first of all a lytic bone lesion is produced. This is a lytic bone lesion. It is produced. After that, there is a periosteal reaction in which the new bone is formed in the form of layers. Layers. Have you seen an onion? Have you ever tried cutting an onion? How does the onion look like? In the onion, various layers are there, layer over layer. The various layers are there. So the tumor is looking, the periosteal reaction of the tumor is looking like that. It is known as onion skin pattern. So there is a lytic tumor over which periosteal reaction is there, the new bone formation in the form of the layers of mineralization. So it is looking like the skin of an onion because the skin of onion is also in the form of the layers. It is known as onion skin pattern. Please learn it, remember it, describe it, and you should be able to identify in the diagram. Grossly, the tumor looks soft, grayish white with areas of hemorrhage and necrosis. It's very aggressive tumor. Microscopically, you can see tumor cells here. Can you describe the tumor cells? Please describe the tumor cells. You can see the tumor cells are blue in color. They are looking like lymphocytes. Have you seen lymphocytes on the blood? The tumor cells are looking like lymphocytes only. They are twice the size of the lymphocyte. But they are very small, round, they are uniform. There is no pleomorphism. They are small, round, uniform. They are blue looking. They have very scanty cytoplasm. In this diagram, I can see only nucleus, the blue color nucleus. I can't see the cytoplasm in any of them. I have drawn the circles, the blue circles. They are the nucleus of the tumor cell. Where is the cytoplasm? Cytoplasm is very scanty, very scanty. Now, if you see the nucleus very closely, it's not visible in the diagram, but if you see the nucleus very closely, now, let me draw a nucleus separately. It is having the chromatin dispersed like this. The chromatin inside the nucleus is like this. This typical arrangement of the chromatin is known as salt and pepper. Have you ever seen salt and pepper? Salt and black pepper. Have you tried salt? It is white in color. And have you please take the black pepper and mix it with the salt. Black pepper is black in color. So mix the salt and black pepper with each other. So how you see black, white, dot, 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 dot. It's like that. So the nucleus is looking like that only. It is typically known as salt and black pepper appearance. Salt and pepper appearance. Because of this chromatin, because it is dispersed finely granular manner. So it is known as salt and pepper appearance. So that is description of the tumor cells you have to learn. Now tell me the arrangement of the tumor cells, how they are arranged. The tumor cells are arranged in the form of a circle. Can you see? They are arranged around something. In the center, there is a pink color fibrillary material. Can you see? In the center, there is a pink color fibrillary material. This one. See here, the pink color fibrillary material around which tumor cells are arranged. The pink color fibrillary material around which tumor cells are arranged forming a circle. So these are known as rosettes. These are known as Homer-Wright rosettes. Homer-Wright rosettes means tumor cells are arranged in a circular pattern with a central fibrillary space between them. Homer-Wright rosettes are there. And see the background. The background is having the fibrous septa. Can you appreciate the background? The background is having the fibrous septa. It can have the bone. Bone is there because it is a tumor of bone. So you can see the pieces of the bone, the bony trabeculi. Areas of necrosis is there, which is not visible here. IHC, you can apply Fly1 and CD99, which is specific IHC for this tumor. So you can appreciate the tumor cells, which are looking like lymphocyte. They are small, they are uniform, they are having high mitotic activity, scanty cytoplasm, salt pepper appearance of the nucleus, and arrangement is in the form of the rosettes. HW, Homer-Wright rosettes. Clinical feature, again, painful enlarging mass is there. It is warm, tender, swollen. Sometimes patient have systemic features like fever, weakness, and bone pain. And sometimes the patient have anemia. WBCs can increase, ESR can increase, the hematological findings can also be there. Spread, since it's a very aggressive tumor, again, local and blood spread. Blood spread, most common to lungs only. Okay, and local spread, it can spread from the medullary cavity to cortex to periosteum to soft tissue as usual. So we are done with this also. So let's revise it quickly. Ewing sarcoma, it is also known as PNET, primitive neuroectodermal tumor. It is also known as PNET. It is a primitive neuroectodermal tumor. Most common age of presentation is 10 to 15 years in children. It is again more common in males as compared to females. It arises from diaphysis. Most common location is tibia, femur among the long bones, and pelvis among the flat bones. Radiologically, it is having onion skin pattern. So there is a lytic lesion, and the periosteal reaction is in the form of layers of mineralization, which is giving onion skin appearance. Grossly, it is a gray-white mass. Microscopically, it is having small round blue tumor cells which are arranged around a fibrillary center, and it is known as Homer-Wright rosettes. It is a painful in nature, and local and blood spread is there. So we are done with all 6 types of bone tumors. I hope you understood it well. Now we will revise this table, comparing all 6 together. You can see the 6 types of bone tumors in front of them. Now see the introduction of all of them. First of all, see the introduction of all of them. Osteoid osteoma is the most common true benign tumor. Osteochondroma is the most common benign tumor but not true. Osteosarcoma is most common primary malignant bone tumor. Osteochondroma is most common cartilaginous bone tumor. Giant cell tumor is known as osteoclastoma, and it is a tumor arising from primitive stromal cells. And Ewing sarcoma is PNET, that is primitive neuroectodermal tumor. Now see the introduction of all of them, learn their other name and learn their most common. What is most common in what? So please learn that. Now see the age of all of them. Can you see the age? Now, osteoid osteoma most commonly occurs 10 to 30 years of age. Osteochondroma occurs in adolescence. Osteosarcoma having bimodal distribution, the primary and secondary. Chondrosarcoma occurs in old age, 40 to 60 years. Giant cell tumors, again middle age or old age, 20 to 40 years. Ewing sarcoma occurs in children. It's 10 to 15 years of age. See, age is very typical. Appreciate the age. Now see the gender predilection. All of them are more common in male. All of them are more common in male as compared to female, except GCT, which is more common in female as compared to male. See the gender predilection. Now see the location of all of them. Can you see? So osteoid osteoma and chondrosarcoma and Ewing sarcoma, they are in diaphysis. These three are in diaphysis. These are in metaphysis. They arise from metaphysis. Which two? The osteochondroma and osteosarcoma. Both of them arises from metaphysis, and giant cell tumor arises from epiphysis. Rather than mugging here, you can see the same in the diagram. I have shown you all of them in the diagram from where they are arising. You can mark them, you can learn them. Coming on their site, you can see the site. Osteoid osteoma, most common site is tibia. Osteochondroma, it's knee joint. Osteosarcoma, again knee joint. Giant cell tumor, again knee joint. So knee joint means lower femur, upper tibia. You can learn them. For chondrosarcoma, it's pelvis, shoulder or ribs. And for Ewing sarcoma, it's tibia or femur in long bones and pelvis in flat bones. Now, you have to learn two diagrams very judiciously. Most importantly, you should learn the diagram, the radiological appearance and microscopy. So I will show you the diagrams. See the radiology of all of them together. Can you see the radiology of all of them? Osteoid osteoma having a central nidus. Can you appreciate a central nidus? A central nidus which is surrounded by a sclerotic bone. So say central nidus surrounded by a sclerotic bone. Osteoid osteoma. Please learn it. Please learn it. The second is osteochondroma. So there is a cap which is made up of hyaline cartilage. The cap is made up of hyaline cartilage of varying thickness. The cap which is made up of hyaline cartilage of varying thickness. Okay. The next is osteosarcoma. Osteosarcoma have two important radiological appearance. One is sunburst appearance. The tumor spread in the soft tissue in the form of parallel mineralization, parallel lines of mineralization, that is sunburst appearance, and it lifts the periosteum. So there is a space between cortex and periosteum, that is Codman triangle. So sunburst appearance and Codman triangle. You have to learn, you should be able to identify it. The next is chondrosarcoma. The chondrosarcoma typically having popcorn calcification and ring-like ossification. Popcorn calcification and ring-like ossification. The next is giant cell tumor. The giant cell tumor having multiple cystic cavities filled with the blood. It is looking a soap bubble appearance. Typically soap bubble appearance. And last is Ewing sarcoma. In Ewing sarcoma, there is a lytic lesion and the periosteal reaction in the form of parallel rows of mineralization. So it is typically giving layers over layers. It is looking like a onion skin or onion peel. It is known as onion skin appearance. So learn the typical appearance with their images together of all these tumors, which is very important. Now the last thing, the microscopy of all of them, the hallmark feature, the microscopy. Looking at the microscopy, you can identify them very well. So one by one, we will revise the microscopy. So osteoid osteoma. First of all, you can see osteoid osteoma. You can see there is a woven bone in the form of the trabeculae. Appreciate the woven trabeculae, bony trabeculae, which are lined by a single layer of the osteoblast. And the background is having loose stroma. The stroma made up of connective tissue, loose connective tissue, along with dilated or congested capillaries. Dilated or congested capillaries. So we are done with osteoid osteoma. Now coming on the next one. The next one, you can see it here. You can appreciate osteochondroma. In the osteochondroma, we are having two portions, outer and inner. Outer portion is cartilage, mature benign cartilage, and inner is lamellar bone and bone marrow. So outer is cartilage, inner is lamellar bone and bone marrow. Coming on the next one we are looking here is osteosarcoma. You can see here osteosarcoma. In this diagram, we can see two things. The malignant tumor cells, the sarcoma cell, that is, and they are forming the bone. The bone is in the form of lace-like pattern. Can you appreciate the tumor cells? These all are tumor cells. Describe them. They are pleomorphic in nature. Some are small, some are large, and they are having hyperchromatic nucleus. They are having mitosis. They are undifferentiated. They form the bone. The bone is in the form of lace-like pattern. Appreciate the form. Bone. It is forming osteoid matrix. So sarcoma cells and osteogenesis. Two things are there in this diagram. Now coming on the next one, the next is chondrosarcoma. Here again, we see the two things. The background is myxoid in nature, the bluish background. The connective tissue is myxoid or mucoid in nature. And in that myxoid or mucoid background, we can see the tumor cells. These are malignant cartilaginous cells. Now, we have to see two things in these cells, their cellularity and their mitosis. And based on which we divide, is it grade 1, grade 2, grade 3. Grade 1 have less cellularity, less mitosis. Grade 2 have borderline cellularity, borderline mitosis, and grade 3 have high cellularity and high mitosis. It's a cartilaginous tumor. Okay. The next one is the giant cell tumor. We can see it here, the giant cell tumor. In the giant cell tumor also, we can see two things. What two things we can see? Mononuclear cell and multinuclear cell. Can you appreciate the mononuclear cell? These all are mononuclear cells. These all. Okay. And these all are the multinuclear cells. These all are the multinuclear. The mononuclear cells are stromal cells. Describe them. They are uniform. They are not pleomorphic. They are uniform. They are plumb. They have scanty cytoplasm. They have prominent nucleoli. So that is mononuclear stromal cells, and they are the tumor cells. And multinucleated giant cells are there. Describe them. They have more than 100 nuclei. Most of them. Coming on the last one, Ewing sarcoma. In the Ewing sarcoma, this is the diagram. Look at the diagram. What you can see? We can see the tumor cells. Describe them. Tumor cells are small, round, looking like the lymphocyte. They are blue in color. They have scanty cytoplasm. They have pleomorphism. They have mitosis. They have necrosis. And they surround they are arranged in the form of a circle around a pink color fibrillary material, and it is known as Homer-Wright rosette, HW rosette. So that's all about it. I hope you learned it. So this is how you have to revise all the bone tumors in one shot. Thank you so much. I hope you enjoyed the lecture. In our app, that is Pathology, Prof Buster. In our course, that is MedLive by Dr. Priyanka Pathology Prof Buster course, long question, short question, very short questions, they are given in objective question bank. So I request all the students who are approaching their university exams of second prof, please see this section. So you will get what long question, what short question, what very short question are asked from this topic in your university exam. And in the this is subjective question bank, I'm sorry. In the objective question bank, you will get the MCQs of this topic. So have a look in our app, or both the question banks are available. Thank you so much. Wishing you all the best. Bye-bye.